Yeah, can you hear her?
Yes, we can hear.
Okay.
We are live.
Okay. So, good evening, postgraduates, and welcome to this. Where is it? 1 minute. Can you hear me? Hello.
Loud and clear, sir.
Yes, we
Yeah.
can hear.
Yes, sir. Yes, sir.
Yeah. So, good evening, postgraduates, and all my namaskar to all the mentors. It's a special occasion for all of us, especially Team ARC and to the past presidents like Dr. Harbansh Lal, who initiated this program. So, let us understand what it is basically. This is a PG teaching program which was initiated by new team of ARCIS almost 3 years back. It was in the month of May when we took over as a new team of ARC, and we wanted to do something, and it was the push from our president who suggested this idea that there is no postgraduate teaching program on behalf of largest ophthalmologist association of the world, that is All India Ophthalmological Society. And that is how this whole concept was pushed into Team ARC. Team ARC labbed it off. And my sincere most thanks to the then President Dr. Harbansh Lal for initiating this particular program and trusting us with the confidence which you gave us. And of course, the backbone was also Dr. Lalit Verma sir, who said, "Karna padega terko, tere paas option nahi hai." That was his words. That's it. He is as curt as that sometimes, but yes, it definitely helped us in moving. And then I came back to my team of ARC, and every one of us thought, why not? Let's do something which will be remembered for generations to come. And with that intention, this is how we started. And it was the first episode we started. We had really jitters. We really did not know what we are doing, what we could do. But slowly and steadily, we started gaining confidence, belief in ourselves. And today we are seeing the 125th episode. And I'm really extremely happy and very pleased with my team for creating such a wonderful experience and a wonderful learning platform for postgraduates of our country. So on this 125th special episode, we have our three main chief guests, I should say, Dr. Lalit Verma sir, Dr. Harbansh Lal sir, and President Dr. Partha Bishwas, who are supposed to be with us and who are going to address our postgraduates about what AIS has to offer and how this program is going on. So just to share a few of the things, statistics with you, we started with short cases. We also we thought what should be the thing, what we can offer as a something different, because there were multiple postgraduate teaching programs which were offering various didactic lectures. So we decided on this particular theme. We decided to move with cases, journal clubs, soft skill boot camps, lectures, and OSCEs. These are the things which are not covered by most of the postgraduate teaching program, and we decided to focus on this. And you can see in the last 2.5 years, we had 32 episodes of short cases, 32 episodes of journal clubs, 4 episodes of soft skills bootcamp, 29 episodes on lectures on topics which are not routinely available to you on any of the platforms. We also had 28 episodes of OSCEs. And look at the viewership. We started with a viewership as minimal as 1,000 parties, means viewership on various Facebooks and YouTube. And today, for most of the episodes, we have 3,500 to 4,000 viewership within a week after the episode is aired. It is not only about the viewership, we have also incorporated and we have seen that this postgraduate teaching program and the opportunities are no longer restricted only to the premier institutes or the bigger cities. As you can see from this India's map, those red dots represent the various parts of the, even the farthest of the northeast area.
Prashant, your screen is not sharing.
Yeah, screen. Okay, it's not seen.
No.
No, I'm seeing it.
No,
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 it's
it's
seen. It's visible.
Yeah, it is seen.
Sorry.
Okay, so even in the northeast or up in the difficult terrains like Jammu and Kashmir, you might see down south, everywhere, every part of the country has been represented. And this particular graph shows the participants' geographic distribution. So the team has made absolute a great effort in incorporating or encouraging participation even from the most peripheral and the most shyest of the colleges in coming on this online platform. And all this speaks about the consistency, commitment, academic rigor, and excellence which whole team of ARC 23, 22, 26 is aiming at. And I'm really thankful to my team, Dr. Srinivas Joshi, Dr. Deepak Mishra, Dr. Kasturi Bhattacharjee, Dr. Anaga, Dr. Tinku Bali for being with me so steadfastly and supporting and taking this through this journey and today to the 125th episode. And with this team, I hope if we make it into the next 10 year, we will reach not only 500 episode, but even more. So before we begin
Cake
something,
cutting. Cake cutting.
yeah,
Cake
we will
cutting. Cake
request
cutting.
virtual cake cutting by Dr. Lalit Verma sir, Harbansh Lal sir, and Partha Bishwas to join us for this cake cutting ceremony.
Yes, 3 cheers.
Thank you, sir. Thank you.
We are all cutting the cake actually, and we'll physically enjoy it during Jaipur conference.
Thank
Sure,
you.
sir.
Thank you.
So,
So with this,
I
now it is my
Prashant,
now it is
Prashant,
my privilege to invite our president, past president, Dr. Lalit Verma, for his small.
no, I am so happy. I am so happy today. Partha Biswas has not joined.
Joined. He joined.
Joined,
Just
sir.
So Partha, as usual, comes late actually.
No,
But that's okay.
8 o'clock. Pakka 8 o'clock आ गया था.
Actually, in any case, so Partha must be today the proudest president actually today. This seed actually, I'm being very straight and honest, was sowed by Harbansh Lal, the past president and one of my dearest friend actually. He sowed the seed for this PG teaching program. And the way this ARC team has carried forward, everybody, and especially the current president, must be proud of. The reason I say so is Partho loves to throw challenges, and he smiles, at every this thing. But he is a very tough person. But he throws challenges. But Bhavan Kule accept with both the hands. You see, whatever Harbansh Lal threw at Bhavan Kule, and he accepted both the hands. Although he said Lalit Verma is a very stiff person or whatever, I take everything those words. But believe me, Partho sowed the seeds of ARC, and I mince no words when she say ARC as a group actually. Before Partho, ARC was hardly doing anything. Partho sowed the seeds. Harbansh Lal sowed the seeds of PG teaching program, and the way Prashant actually has nurtured ARC, the way, am I audible? No.
Yes, sir. Yes, sir.
For
Absolutely.
audible.
Yes,
And
sir.
the way Prashant has nurtured ARC and the passion with which he gets involved. I don't know where he gets the energy from, but he gets engrossed in all his activities. And I have attended a couple of his, ARC activities in the conference also, as well as, and I've sat glued for a couple of hours with Tinku Bali and so many other, with Deepak Mishra. So they have done phenomenally well, and I wish that they continue. Somehow AIS needs them. They should come back with a resounding victory also. And I hope the entire ARC team under the leadership of this small giant part, Prashant Bhavan, I call it small giant, but he's a giant. Believe me, he's a giant. And all of them must be today very happy, and must be. There is a cause for rejoicing today. And we already had cutting the cake in the absence of Partha Biswas. He joined slightly late. But believe me, as I was telling you, not long ago, I was deep into AIUS when there was hardly any activity in ARC. And there was used to be, we used to think in OBSC to revise its role. Bhai karna kya hai ARC ka? But you see today, not only we are celebrating 125th episode of one of their activity, only PG teaching की बात कर रहे हैं. 125 सचिन तेंदुलकर सेंचुरी पार कर दी है प्रशांत भवन कुले ने. This minuscule chairman, छोटा सा, but he does phenomenal job, phenomenal. And I could, believe me, see Prashant coming this. And that is reason, that is one reason, and all of you are witness to that. We increase the seats of ARC members from 5 to 10. Because इतना काम करने लग गए ये लोग after Partho sowed the seeds of ARC and took it to so high level, and Prashant hasn't let anybody down. उसने बहुत मेहनत कर दी है. But I would just advise, don't get overboard by your achievements. Keep working hard. There's a lot more to achieve. And the only thing, Prashant, which gives me a lot of happiness is the way you showed the graph on the left side, India, every city, country you have taken. And that is what I had told that Prashant, तुम्हें छोटी छोटी जगहों पे जाना है, because you see our dream, and I know what Harbans Lal had meant, is that you see PG teaching, whether in Patiala, whether in Kakinada, whether everywhere, should be similar. And AIS has that onus, has the responsibility that everybody should have similar teaching, similar kind of exposure. Baki to baki kismat hai, how much they learn, how much they have the skill set, how their job they get placement and all. But AIUS under ARC is not lagging behind today, and I'm very proud to be associated with this team. But don't get overjoyed, don't get overbuoyed. Celebrate karo. I'm not champagne will open. There's no doubt. आप केक ले आए, but I was wanting a champagne actually. But keep working hard, keep working hard. And I wish you all the very best. But keep interest of the members in the forefront. What do members want? You see, these 28,000, 30,000 members, Partho and Prashant, they are looking towards you now. They actually, believe me, once Tinku Bali was doing an episode, मेरी fellow sir, हमने आज जाना है, हमें वो episode करना है. Believe me, आज भी शायद they must be glued. I told them. But keep the interest of the members in mind, and I wish you all the best, and see more and more of these celebrations coming your way. With these words, I convey my best wishes to Prashant, the entire team. Srinivas Joshi, why are you so sad? You should be rejoicing.
Thank you, Lalit sir.
All the best. Thank you.
Thank you for those quite fattening type of a dose of this. We are extremely delighted as a team. Can I now have some a piece of advice from Harbans sir? It was his dream. How does he look at it? Last 25 episodes, and what does he have in his vision for next 125 episodes as a team for ARC?
In a nutshell, I'll say actually I'm really proud of Prashant, the way you have managed the show and whole of your team. I mean, it is beyond even what I imagined. You actually delivered more than that what I had imagined actually. So I had that thought in my mind that there are many places where the teaching is not so good because the faculty is small, the people are busy in writing the files and doing the surgeries, running the OPDs. Like when my daughter was about to get the admission. So when I came to know that I wanted to send her to the Bombay, then I found out the medical college got only 2 or 3 faculty. I said with the 2 or 3 faculty, you can have 2 or 3 PGs at the most every year. So how much you can really sit down and discuss actually. You need to at least 15, 20 people sitting in a class so that the teacher feels enthusiastic and you have got some of them will be busy in the ward so that the PG teaching can really go forward. But with this creation of this platform now, irrespective whether there are 2 professors in your department or there is a 1 professor. I mean, I know in a UP Medical College for many years, there was only 1 professor in whole of the medical college looking after 4 or 5 PGs. He was doing the OPD also and he was running the OT also. So I don't think how much he can actually teach. So many of our medical colleges are actually understaffed. And then in that scenario, the finishing of the clinical work and OT duty takes a priority over teaching. So the platform you have created and the way you have imagined and covered everything, I mean, short cases, long cases, and the general club. So virtually, and as we were discussing before you and before the actual official this thing is started, that many medical colleges, they don't make their teaching program now where there's a small medical college in the periphery. They just put up this ARC program and sit down along with the student and discuss the same thing over there. So they said, once this wonderful program is going on, why to make our own program? And then they got for the program which has got already 125 episodes, which they can go and revisit any one of them they want to revisit. Not only what you are seeing live, but you have got a full library to go and see if you have got a particular type of a case. It must have been discussed somewhere earlier. You can go and see that type of a case in our platform, in the ARC platform. So, but as Lalit has already said that before the Partha Viswas joined the chairman ARC post was actually more or less defunct type. And we're really wondering what is the role of the ARC but then Partha did a huge work and he made this post really glamorous actually, if you look at it. And really it was the one post now people wanting to do it. And Prashant, of course, had a great desire to contribute as a chairman ARC, though he had an option, an easier option to go for the post. But he stood his ground and went for the post where he thought he'll be most useful. And I think his vision and his thought process was absolutely spot on. He took the right post and delivered to the IUS and its members a very high standard of PG teacher program. And of course, he has got a very dedicated team of Deepak Mishra, Srinivas Joshi, Anaga Herur, and Kasturi Bhattacharji and Tinku Bali. And they have been really, and it was, he has the ability to take work out of them. He is so polite and humble. Whenever he says something, I think none of them are able to say no to him. So it was his capacity that even at the 11th hour, we said somebody has to conduct the show, they will come on the screen. So thank you, Prashant and team, for doing a wonderful job. I really feel proud and happy that I initiated it. And thank you for remembering. Thank you. Wish you all the best.
Can I request President of AIOS and the past Chairman ARC, who has brought ARC to the glory, to let us hear from him what he has.
So thank you very much, Prashant, for giving this opportunity on this real gala celebration of 125th episode of your PG teaching. It's an icing on the cake, actually. The cake has been there, but you've really iced it so well that it looks glamorous. And I'm so proud that ARC, where it was to where we left it after my 2 terms of ARC, it has really gone way ahead. And it's not you only, it's your whole team who have done miles and miles of hard work. And this is the effect of it is. And believe me, I think the PG teaching is something that is so important for us at AIOS, because it is where there is inequality over so many institutions of the country. Each institution tries to do its best. Unfortunately, the capacity is not there. And since the capacity is not there, and at times the government is unable to fulfill that equality. And when it comes to this, what do we do? Do we let our postgraduates who are going to become ophthalmologists in the future years become half-baked ophthalmologists? Not at all. And that's the reason Dr. Lalit Verma, Dr. Harbansh Lal, and all of us have thought so deeply about the education parity of the postgraduates in their residency programs. The residency programs, the READS program that we did, the READS survey that we did 10 years ago, and we are doing it now once again, 10 years later, is going to show us where AIOS has actually made a difference. We have made a difference, and it is through your great efforts that this difference has been made. But let us also remember that many of us have come from medical colleges where we were impoverished for knowledge. There are medical colleges in which it's not a part of history at all, it's still a reality, where the slit lamp is locked up and you do not get an access to the slit lamp as postgraduates. There are medical colleges and where postgraduates have given a kitty so that they could, 3 or 4 of them could buy a slit lamp and they could see the patients in their postgraduate residency. So such is the state. So let us remember from where we come and where we need to go. And this is where AIOS has really given strength, and the ARC does this human service for the postgraduates by this program. Thanks to Dr. Lalit Verma's great insight, his inspiration when I was chairman ARC, Dr. Harbansh Lal, when he actually proposed that what needs to be done, even that extra mile needs to go. So this has given rise to this, and I'm sure the next years of ARC is going to give an impetus for even greater horizons. Today is a very sad day for me. My professor, Dr. Mangturam, just passed away, but had committed to Prashant that I'll be here. So can I have just 1 minute of silence from everybody?
Thank you. Thank you, everyone.
Thank you very much. Thank you, everybody.
Thank you, President Sir, and my sincere most condolences to the departed soul and a very respectable teacher from our country. So now let's move on. I will request all.
Officially, I think ARC team should offer official condolences to.
Be sending it.
Yeah.
And can I request all my members to speak for a minute, because everyone has worked hard. Everyone has something to say. I know this is an academic activity where the mentors and today's moderators must be waiting for us. But today, I think it's.
Prashant, 1 minute. I want to listen from each member.
Yes, yes. So we will start with Dr. Seniority wise. So Dr. Kasturi first, ma'am.
Okay, I should extend my heartfelt congratulations to Lalit Verma sir, then Harbansh Lal sir, Parthada, and also to whole of AIOS and ARC team under the chairmanship of Dr. Prashant Bavankule. And on this remarkable milestones of completing 125 episodes of ARC academic series, I should say that everyone is very much committed to this structured and very high quality education. And this is really, as mentioned by all my seniors and teachers, that it has significantly contributed to the continuous learning, skill enhancement, and academic excellence across not only the PG students, but also the whole of the ophthalmic community. That is what I have seen, that even it has really helped everyone who are practicing ophthalmology. And this really shows the consistency, the relevance, and the reach, which Dr. Prashant has also mentioned. From 1,000, today it is more than 4K. So this really reflects the vision and the dedication of the entire team, the whole of AIOS under the chairmanship, and the ARC team under the chairmanship of Dr. Prashant. And I congratulate everyone, my team, and everyone from AIOS. Thank you.
Thank you, Kasturi ma'am. Now next in order would be Dr. Anaga, please. I think we are missing Anaga. Okay. Then we have Dr. Tinku.
Hello, Dr. Prashant, and thank you to all the seniors for being so supportive and for their presence here this evening. Well, when we started with this PG teaching program, our mandate was very simple: to make quality academics accessible to every PG, even in the remotest part of the country. And I think we have been successful in doing that, and following Dr. Prashant's mandate. I would like to just highlight the role of all the faculty that has been so supportive throughout these webinars. They've made everything so practically relevant for our PGs, given so many practical pearls. Also, they have made it exam oriented. They've taken the trouble to go through past question papers, bring out the questions, and, incorporate them into their talks. So hats off to all the faculty. The PGs have been equally enthusiastic. They've been messaging, giving us suggestions, constantly bringing up questions and pushing us to do better with every episode. I would say the two highlights of this PG teaching program have been the journal club and the case presentation. So journal club is something that is, hardly ever touched upon in a lot of PG institutes. So through these journal clubs, the PGs have got an insight into how to actually analyze a journal article and critically evaluate it. And the case presentations have given them, a mock exam scenarios, given them more confidence on how to face exams. And I have been so impressed to see even first year residents, coming on a national platform and presenting their cases so confidently and fielding the questions asked by the examiners so very confidently. So it's been really heartening. So thank you, Dr. Prashant, for tailoring this and curating this program so well. It's been a a two-way journey. It's been a lot of learning for us also. We've learned so much through all the episodes, and it's always great to be connected to young minds. So all in all, Dr. Prashant has been a great leader. He's been, he's delegated work to everyone and kept us all so much involved throughout everything. So thank you so much. Thank you, Dr. Prashant. And thank you to all the seniors, Dr. Lalit Verma sir, Dr. Harbans Lal sir, Dr. Partho Bishwas, for, being so supportive throughout this journey. And hope ARC continues this journey of being supportive to the PGs and all to all the ophthalmologists across the country. Thank you.
Tinku. Dr. Anaga has joined. Anaga, you can express, please.
Dr. Anaga, I think, is ready with a poem.
Yeah, she has a poem she's written.
It's frozen. So I think Dr. Deepak, Professor Dr. Deepak Mishra from BHU.
Good evening, everyone. It's very difficult to say in the presence of Lalit Verma sir, Harbans Lal sir, and Partha Biswas sir. Sir, I started what I can say. I joined my first PG program in DOS when Harbans Lal sir had started DOS PG teaching program and Lalit sir. And then I organized my first ARC PG teaching program at BHU in 2015 when Dr. Partha Biswas sir given me the opportunity. And in SSTC, I am just because of the Dr. Lalit Verma sir, he has given me opportunity. Similarly, the Prashant sir has given me a lot of affection and faith on me. And every time when I went to him with whatever the idea for the PG teaching program, because as Tinku ma'am said, we, apart from the regular journal club and this case presentation, we also target some different kind of webinars too, like soft skill development, how to approach. And recently we go for the medical legal cases, or the how to prepare, our PG should know how to deal with such cases. And all my ARC members are so supportive for me that I cannot express their thanks for everything. And from the whole team of the ARC, I am very, very grateful for all the teachers who accepted us, and still they teaches us in their webinars, and again all the PGs. Thank you, sir. Thank you whole team for reaching this milestone. Thank you.
Thank you, Dr. Deepak. And last but not the least, my right left hand, Dr. Srinivas Joshi, who I think, as Lalit sir said, why he is looking slightly sad. Let us hear from him.
Thank you, Prashant sir. My pronouns to all the seniors, Dr. Lalit Verma sir, Dr. Harbans Lal sir, President AIOS, Dr. Partha Biswas sir, and our dynamic chairman, Dr. Prashant Bawankule sir, for taking up the legacy of ARC. So when Dr. Prashant Bawankule in the initial days, I think Dr. Tinku, Dr. Kasturi, Dr. Deepak, and Dr. Anaga will remember that he was so pushy that karna hai, kuch to karna hai, Srinivas, kuch to karna hai. I said, sir, let's do it. When Harbans sir was at the helm of the affairs of AIOS presidency, then he said, let's do it. Then we thought that, see, most of the postgraduates are already learning from the textbooks, they're already learning from the lectures and all those things. So how we defined this PG program with the difference, what Dr. Prashant has named it was, let's have the short cases and the long cases. What we have found out in most of these PG educative programs conducted by ARC is students are very fearing in facing the examiners. Most of the theoretical lectures and classes they listen, they have the webinars, they have multiple programs, they can listen it. But what questions will be asked in the exams, I think that is the most highlight of this entire program. So that is where we focused on making it into a short case discussion, long case discussion, and the journal club. The journal club, we designed it in a way so that the postgraduates who are in the remote medical colleges who do not have access to most of these instruments or the updated technology, but still need to get updated about what is happening around ophthalmology. And then he named it as Saransh. That is a 15 minutes. That is telling about what the gist of what is the updated in that field and what needs to be the take-home message, the clinical application of that. And then we thought, what about apart from the case presentations, what about next? How to read the charts, how to read the HES chart, how to read the diplopia chart, the retinoscopy, the forgotten art. Then let's try how to see the OCT, because few of the medical colleges, unfortunately now most of them have it, but some of them do not have the OCT, OCTA, fluorescein angiography, ICG angiography. So we thought, let's try to make it a chart based, try to give them, and then try to see if we can overall try to cover most of these and try to ask the questions in the form of OSCE format, because the DNBs have the OSCE format. And luckily, when we first initially started, it had around 800 to 1000 views when I personally checked it. But I was so fortunate that I should be thankful to an entire team of ARC. Think Dr. Tinku, Dr. Kasturi, Dr. Deepak, Dr. Anaga, who held the mantle. And then I could see Dr. Prashant in most of the programs. I think he has revised it so many times that if he sits for the exams now, probably he will earn a gold medal rather than in those days. So he will re-earn that figure back. So I should thank my entire ARC team who did an excellent job, because just framing the program and pass it on is not important. Who sits for that entire episode? That is very, very important, because doing 125 times and every one of us had to spare 125 hours. It's not just 125, sometimes it used to go 2 hours. So take it roughly 150 hours. All are busy clinical practitioners. But again, they tried to do so much for this. I think the hats off to my entire ARC team, led by Dr. Prashant Bhavankul and entire seniors of AIOS for conducting it so well. So the baby which we started has now completed 125th year. It's such a proud feeling, right? So thank you very much, AIOS, for giving us all these ARC members this opportunity. And please believe us that if any job given to us, we'll try to make it more successful in the coming years together. Thank you very much.
Thank you, Srinivas. Anaga, can you come on the... Oh, no.
Poem लिखी थी ना वो?
You are muted. You are muted. You would like to say something? Oh, I think we are missing her. Okay, her link.
Hello.
We can hear you. Anaga, you would like to say something?
Okay. Yeah. Sorry for the poor signal from my side, but would like to thank so much Dr. Lalit Verma sir, Dr. Harbansh Lal sir, and Dr. Partha Biswas sir for leading AIOS and bringing ARC to its present glory. Like to thank our chairman, Dr. Prashant Bhavankule sir, and our entire ARC team. Would also like to thank all the teachers, the mentors, the students who took part in our programs and made it such a big success. And I have just written a very short poem, not just lessons or passing slides, but sparks of hope where learning thrives, a guiding voice, a steady hand, shaping healers. And 125, yet we will see learning as a shared humanity, where wisdom flows both pure and true from the teacher's heart to minds made new. So ARC has always been at the forefront of not only the PG programs, but also so many other innovative ideas. And thanks to all the AIOS members for the support, and the AIOS who always stood by us, and to our entire. Thank you so much.
Thank you. Thank you, Dr. Anaga, for expressing your feelings for the program and the whole AIOS team. So now, friends, let me again thank our chief guests, Dr. Harbansh sir, Dr. Lalit sir, and Dr. Partha Biswas for sparing their valuable time for our postgraduates and gracing this very happy occasion for Team ARC. Now, without much ado, can I request today's moderator for today's program, Dr. Deepak Mishra, to carry forward the proceedings. We have already delayed the whole proceedings, but I'm really sorry. We were very excited because of the 125th celebration. So we had to barge upon it. So postgraduates, we are really sorry, as well as all the mentors and the program coordinators. Please, Deepak, go ahead.
Thank you, sir.
Yeah, now adding one more hour, it's 151 hours. We should congratulate all our ARC members for that, and including the so busy time in all the busy clinical practice. Thank you.
Thank you. So, sir, the today program is basically on the short cases. And we are lucky that we have the examiner of the examiners, Dr. Pradeep Jain sir, who is the director and consultant at Jalna. Dr. Sunita Dubey ma'am, she is the medical director, Sarafai Charity, Delhi. And Dr. Deven Sood sir, who is the senior glaucoma consultant at Max, New Delhi. And today case presentations were from the two different institutions. One is from the Chaitram Netralaya, Indore, and another is from JNMC, Belgaum. And the mentor from the Indore side is Dr. Amit Porwal, and the mentor from the JLMC Belgaum is Dr. S.C. Babu Nale sir. And today we have two young dynamic presenters. One is Dr. Afreen Khan. She is the third year DNB from the Chaitram Netralaya, Indore. And then we have Dr. Nivedita. So I would like to invite first Dr. Afreen Khan for her presentation on the glaucoma masquerade. Dr. Afreen, please.
Yes.
Kindly share your screens.
Is it visible, sir?
Yes, yes. Make it full screen, please.
Make it full screen.
Yes, sir.
Yeah.
Fine. May I start?
Yeah, good.
So, good evening, everyone. Myself, Dr. Afreen Khan, DNB resident from Chaitram Netralaya, Indore. And my mentor for today's case is Dr. Amit Porwal, who is head of glaucoma services there. So, I'm going to present a case of 38-year-old male who is army personnel by profession. He was previously diagnosed as a primary open angle glaucoma case elsewhere, and he presented to our clinic for routine checkup. He was instilling eye drop brimonidine twice daily since 3 years in left eye. Also, he had previous records which showed CCT, central corneal thickness of 515 microns in right eye and 500 microns in left eye. His visual field records were also there, which showed superonasal arcuate scotoma in left eye and right eye was within normal limits. So on general examination, everything was within normal limits. Systemic findings were also normal. His best corrected visual acuity was 6/6 and N6 in both the eyes. On ocular examination, conjunctiva and cornea were clear. The anterior chamber was deep with VH grade 4. Pupil was 3 mm circular central reacting to light in both the eyes. The lens was clear in both eyes. The intraocular pressure by Goldman applanation tonometry was 15 millimeter of mercury in both the eyes. The gonioscopy done by Goldman 4-mirror gonioscope showed ciliary body band in all the quadrants, 4 quadrants. On fundus examination, the media was clear, right eye. There was normal disc size, which was pink, well-defined, with well-defined margins. The vertical cup disc ratio was 0.4:1. Foveal reflex was dull, had normal retinal vessels and tessellated background. In left eye, the media was clear. The disc was comparatively larger as compared to the right eye, but it had well-defined margins and the vertical cup disc ratio was 0.4:1. It also had an inferotemporal grayish excavation of disc. With edema in the inferotemporal nerve fiber layer, the foveal reflex was dull and normal retinal and tessellated background was present. So according to these findings, we made a provisional diagnosis of right eye emetropia and left eye emetropia with optic disc pit with inferotemporal RNFL defect. So we investigated the patient for both eyes. OCT disc and macula was done and both eye visual fields were done. CCT was, as we had previous record of CCT, so we didn't do it again. So in OCT, in HD21 of right eye, it shows normal foveal contour and the RNFL thickness map and macular thickness, everything was within normal limit. Whereas in left eye, the HD21 scans showed a deep excavation at the disc, inferotemporal disc margin, which is suggestive of optic disc pit. But the foveal contour was within normal limit. The scan taken just below the inferior margin of the disc shows a thickened inner retinal nerve fiber layer with some cystic changes. On RNFL map, we can see there is an inferior wedge-shaped defect more in the inferotemporal quadrant as compared to rest other quadrants. So comparing the both eyes, RNFL and optic nerve head, we can see that left eye had more cup disc ratio. It has a more prominent disc with an excavation and a wedge defect in the inferotemporal quadrant. Surprisingly, both the macular thickness were within normal limits, except the inferior quadrant of left eye had a small thinning, less thinning. On Humphrey visual field analysis, right eye was within normal limits, whereas in left eye, we can see that there is superonasal arcuate scotoma, which corresponds to the RNFL defect we found in OCT. So our definitive diagnosis was right eye emmetropia, left eye emmetropia with optic despite with inferotemporal retinoschisis. Since the patient was asymptomatic without any apparent glaucomatous disc changes, so we stopped the AGM and patient was called for subsequent close follow-ups. On subsequent monthly follow-ups, till 4 visits, patient was asymptomatic and his pressures were well controlled without any topical medication. So this case discusses about a misdiagnosed glaucomatous disc, which was actually an optic defect, and the visual field defects which was seen in visual field analysis were due to the peripapillary retinoschisis, which is a common association with optic defects, and not because of glaucomatous damage. So thorough clinical examination with absolute precision is most essential to diagnose such cases. The discussion part, we all know that optic defect is a rare excavation of optic nerve head. It can be congenital or acquired, unilateral or bilateral, solitary or multiple. Usually they are asymptomatic, but if it is associated with maculopathies, then it can cause severe visual impairments. Also, the incidence is rare, 1 is to 11,000, out of which 70% are temporal and 20% are central. The abnormalities which allows the fluid to enter the pit initially causes a Schiatic-like separation of inner layers of retina. It can also lead to centrocecal scotoma. As the condition progresses, it causes macular hole in the outer layer and ultimately resulting to serous retinal detachment. Also, it can be very commonly confused with optic disc coloboma. The differentiating feature is optic disc margins gets obscured in the case of colobomas, while it remains intact in optic disc pits. Thank you so much.
Thank you, Dr. Afrin, for summarizing the whole case in a scientific way. Dr. Deven Sood, sir.
I think I must congratulate ARC for the wonderful job it has been doing for the last 124 occasions, this being the 125th time. This particular presentation, both the mentor and the presenter need to be congratulated for highlighting a very important point. A very good and clear presentation from the presenter. You know, one of the questions as the history proceeds is, why was treatment started only in one eye, considering that glaucoma is usually a bilateral disease, asymmetric in presentation? So these are concerns that come up. The second thing was, if you look at the current definition for glaucoma, it says, irrespective of the intraocular pressure, if you have structural damage, which your current level gold standard OCT is picking up, and you have a correlating functional loss, the patient needs treatment. But here you have a congenital anomaly which is mimicking or fulfilling the bare criteria for diagnosing glaucoma. So I think technology is important, but the technology needs to be correlated clinically, and this presentation highlights that very well. So congratulations to the person, the mentor and the presenter for highlighting the importance of clinical examination in glaucoma and not just depending on technology for diagnosis and management.
Afrin, can you please unshare the screen? And I would request the examiner to take it as a short case happens in a DNB or a MS final, and you can quiz her.
I would like to just go back to the optic nerve evaluation. Very well presented and very good documentation. of all the investigations being done for glaucoma. So congratulations to both presenter and the mentor. So just the examination, I think, since Dr. Sood has very well explained that glaucoma is a bilateral condition, and optic disc pit is generally unilateral, although it can be in rare occasions bilateral. So when you go back to your optic disc evaluation, you said the left eye disc was 0.4. So you can just explain, like how did you comment that it was 0.4? How do you check for the vessels and all in that particular case?
Yes, ma'am. Yes, ma'am. While evaluating a disc, we have to see how the vessels are exiting. So that is the disc margin, cup margin, sorry. So in this case, the vessels were just evacuating at 0.4 CDR, and the pit was present inferiorly, and it was isolated from that of the cup. So
you could clearly see the second bend of the vessel
demarcation.
in demarcation, and there was clear-cut difference in the size of the optic now. Okay, so is it a masquerade, or it's like what are the different masquerades you're saying? And you just gave one DD that you can have optic disc coloboma. Are there any other conditions which can mimic glaucoma? And how is it different from if follow up the patient over a long time? So what will be the difference between this and true glaucoma?
Ma'am, in congenital cases, the DDs can be optic disc coloboma along with optic disc pit and morning glory syndrome or optic disc hypoplasias. And in acquired cases, in advanced cases of glaucoma or in myopia, we can get optic, due to thinning of the lamina cribrosa layer, we can get the fluid invagination into the retinal layers and can cause maculopathy. So in myopics and in advanced glaucomas, we can find that.
So how can, is it progressive? Because glaucoma is a progressive condition. So is it progressive? How will
Optic disc pit?
Yeah.
Ma'am, in 75% cases, it is non-symptomatic, asymptomatic, and if it involves the macula, then in 25 to 75% cases, it causes subsequent centrocecal scotomas, and then macular hole, and then serous retinal detachments. But mostly it is asymptomatic only, and we have to keep them in close follow-up. And we have to explain to the patient that you have to come immediately if you see any signs of diminution of vision.
It's not a progressive optic neuropathy. It can cause maculopathy because of that schisis.
Yes, yes, ma'am.
Okay.
Yeah. Very well presented, Afrin. Very nicely presented. And as Dr. Sood said, you should have your good clinical diagnosis. Like instead of depending on that all tools, your clinical judgment is very important. Like so, 78 diopter examination and fundus examination with all other things. And Afrin, one question from my side: how you follow this patient? How should you follow? Because there are chances that this patient may develop open angle glaucoma. So, like, how should you follow this patient?
Initially, we'll keep them in close follow-ups, and then every 3 monthly follow-up can be told. And the patient is especially counseled about the danger signs, and he can be given an Amsler grid so that he can check the vision or any diminution or distortion in vision at home.
So I think OCT and field maybe yearly. Yeah.
Okay.
Dr. Sood?
Yeah, I'm actually,
follow up for this patient.
So I don't come from I'm not with a clinical teaching institution, so perhaps there's a difference in the questions others have asked and the way I have commented. My apologies for that, but I'll just like to comment and say progression will happen in this case as the fluid accumulates at the macula. So you would need to ask yourself when you're depending on fields and OCT, is the progression or worsening because of the possible glaucoma changes happening, or is it because of the macular involvement? So again, clinical examination will help differentiate this. I'm repeatedly saying this because these are, as Dr. Sunita said, a masquerade syndrome. Progression becomes difficult to assess also in these situations. But the thing is, the glaucoma is usually non-progressive in nature. And the diagnosis of glaucoma, again, traditionally would be based on the intraocular pressure, the optic nerve, the visual fields, and the gonioscopy. So here you're likely to find that the structural changes on OCT and functional changes on visual fields are perhaps progressing, but a good clinical examination will help you negate the concept of progression and make sure that this patient is accidentally not started on treatment. If you go back to the history taking again, there is a clue there. Treatment was started only in the left eye. So whoever probably saw him did it on the basis that the disc, on the appearance of the disc. The other factor that Dr. Sunita was asking was about the vessels. You will find that blood vessels usually don't cross the pit. They will go around the margins of the pit and then exit at the disc margin. So I think the key here would be a good clinical examination will carry you through to say that this progression or diagnosis is not warranted.
And Dr. Sood, other eye, the normal eye. So follow-up for that also is very important in this case. If this right normal eye, if they develop field defect or maybe glaucomatous changes, then definitely.
Yes. So I will add to this and say, we are not treating one eye or observing only one eye. When the patient comes, we are examining both eyes. The question which would be is, does this optic pit put the patient at a higher risk for developing glaucoma with time as compared to a person with no optic disc pit? I don't think that's true. I mean, the experience doesn't say that. But yes, observation would remain the same. This patient can develop glaucoma like any other normal person.
Correct. So the normal eye examination is also very important for Dr. Afrin, because otherwise there's a defect in the left eye, field defect in the left eye, changes in the left eye. So many times we focus for the affected eye and we neglect the normal eye. So I think the right eye examination is also very important for at every visit. Thank you, Dr. Afrin.
So one additional point that comes out for a unilateral glaucoma where patient has come to you on treatment is uveitis. A past patient could have developed a flare in cells and a secondary glaucoma with an optic disc pit. That is something that needs to be kept in mind.
Thank you, sir.
Although I think I will further stress that the optic disc clinical evaluation, I think, is the most important. When you look at both the discs, I think that was a very clear-cut, difference between the two discs. And then you go on to do the investigations. So I think that is the most important. Still, optic nerve head evaluation is the most important part of your glaucoma evaluation.
Before we go to the
disc picture. Yeah, with the disc picture, I think that is very, very important. If you have the facility, and even fundus picture with the focus on optic disc is very important. Yeah.
Before we invite the next presentation, one short comment from the mentor, Dr. Amit. Amit, why do you think you chosen this case for the?
Yes, so to all the judges, just to highlight how well the information or education about glaucoma was passed to this patient. This person was from army. And he came to me. When I diagnosed, I told him we don't have glaucoma. He took out his fields and he started teaching me. ये देखो ये defect है, यहाँ मेरे को दिखता नहीं है. He took out his OCT. So he was well educated by the treating ophthalmologist that these are the field defects because of which you are having glaucoma. So what I'm trying to say is patient was not diagnosed as glaucoma based only on disc evaluation. The way he told me, it was basically the field defect which was shown and the OCT RNA field defect which was there. That was shown to the patient. So that's why it's a masquerade. Why this case highlights is we should not treat brand a patient as glaucoma based on these defects on the visual field or on the OCT. So any patient of optic pit comes with this type of defects, we should do an HD21 line so that if any chysis is there, we should correlate that with the field defect. So that's what we did here, and we explained to the patient, and then he was convinced to stop the anti-glaucoma. He was like, मैं तो दिल्ली जा रहा हूँ वापस, मेरा आर्मी हॉस्पिटल है वहीं चेक कराऊंगा. And when I convinced him and he came for follow-up, he realized, and I told him also, go whenever you are getting transferred, make sure if anybody tells you have glaucoma, you want to start a treatment, take a second opinion, take 2 opinions, and I've already educated you about the OCT and the field. So you also try to analyze. So educating the patient in a proper way is very important. That's what I would like to say. Thank you.
Very
Well presented, our friend.
Thank you. Okay. Dr. Nivedita, may I invite Dr. Nivedita to present her talk. Dr. Nivedita. I think
she has to share the screen also.
Sunil, can you just help her in sharing the screen?
She's stuck. Her photo is stuck. I think she's having some network issue. No, yeah. Your screen is visible, Dr. Nivedita. Meanwhile, she is. We are unable to hear you, Dr. Nivedita.
Hear me.
स्पीकर पे डाल.
Hello. Hello.
Do again leave in this thing that.
Shiva, you are in the department or she is presenting from the house?
Hello.
Shivanam?
Hello, sir.
Yeah, can hear you, Nivedita.
Yes, yes.
Yes, sir. Can you hear me, sir?
Yeah.
Yes, yes, yes.
Okay. Sir, I'll share my slides.
Sure, sure, sure.
Sir, everyone, can you see my screen?
Yes, yes.
But Doctor, click on the screen if you can just change the slides.
Good evening, sir.
Yeah, it is visible. Can you click on the screen and change the slides?
Okay, sir.
Yes.
Shall I start my presentation?
Yes, yes.
Yes, sir. Good evening, everyone. So I'm presenting a case, 60-year-old female patient coming from Belhongal, who is a housewife, has presented to her OPD with the chief complaints of diminution of vision in both eyes, left eye more than right eye since 3 years. So the patient was apparently all right 3 years back, when she started noticing diminution of vision in both eyes, left eye more than right eye, for distant and near vision, which was gradual in onset and progressive in nature. History of use of spectacle was there since 3 years. There is no episodes of redness, watering, or photophobia, colored halos, no history of associated nausea, vomiting, or headache. Patient underwent Indiac laser peripheral iridotomy 3 years back, and the patient was already started on brimonidine 0.2% plus timolol 0.5% eye drops 2 times per day on left eye, and bimetoprost 0.02% eye drops at night on both eyes. The patient was in between and now came back again to Kelly Hospital for further evaluation and management. So patient is not a non-case of diabetes, hypertension, bronchial asthma, or ischemic heart disease. There is no significant similar complaints among the family members. Personal history is also within normal limit. So going to general examination, a middle-aged female patient who is moderately built and nourished, who is conscious and oriented, with no pararectal sinuses, clubbing, lymphadenopathy, edema, with vital stable. And systemic examination is also within the normal limits. So going towards the ocular examination, head posture is normal, facial symmetry is there, ocular posture is normal, and visual axis parallel. So uncorrected vision in the right eye was 612 parts, improving to 6.6, and left eye was 618 parts, improving to 6.6, with near vision of N12 on both eyes, and color vision within normal. Best corrected visual acuity is 6.6 and with N6 on both eyes. Extraocular movements were full and free in all quadrants. Going to the anterior segment in the right eye, the positive findings only I am elaborating, sir. Conjunctiva was showing circumcorneal congestion, cornea was clear with a VH grade of Van Herix 2, with anterior chamber Van Herix 2 grading, and iris was showing a peripheral iridotomy at 12 o'clock, which was not patent, and a patent PI at 1 o'clock position with round reactive and regular pupil and NS1 cataract. Anterior segment left eye. So it's also showing circumcorneal congestion with mild hazy cornea with a mild epithelial edema, with anterior chamber showing Van Herix grade 2 and a patent PA at 2 o'clock position with grade 1 RAPD and NS1. So IOP are done by GAT with the patient was already on anti-glaucoma medications. On multiple sittings we had done. In the right eye, it was ranging from 14 to 20 mmHg, and in the left eye, it was among the range of 22 to 26. So while doing a gonioscopy by 3-mirror Goldman mirror, according to Schaffer's grading, posterior tubercular meshwork was seen in the superior and the temporal quadrant, which is suggestive of grade 2 of Schaffer's grading, and only Schwalbe's line was visualized in the nasal and inferior quadrant, suggestive of grade 1, and peripheral anterior synecdoche was noted in the nasal and inferior quadrant in 1 clock hour. Similarly, grade 1 Schaffer's grading was noted in the nasal and inferior quadrant, and superior and temporal quadrant was showing grade 2 Schaffer's in the left eye with peripheral anterior synecdoche in nasal and inferior quadrant. While doing this shapes vertically oval with cup vertically oval with wet defined with a CD ratio 0.6 with entire thinning and nasalization was noted. AV ratio was 2:3 with normal background, and FR was dull. While going to fundus examination of left eye, glow was present, media was clear with clear margins, and the ratio was 0.9 with NRR thin laminotes and with AV ratio of 2:3 and FR was dull. So the right way was reliable, and with the normal limits, there was no visual field defects. Going to left eye HFA, first I had done a 30-2, which was showing tunnel vision. So pattern deviation was not able to find out. So I had 10-2, which was showing a 3-quadrant involvement in the visual fields. Then we had done OCT, ONH, and RNFL. So it was a reliable scan with a good signal strength. And the right eye was not showing much RNFL thinning, but the left eye was showing, as we can see, the RNFL thickness map is full blue and green, suggestive of full RNFL thinning. And going to the quadrants, superior, inferior, and temporal quadrant was showing RNFL thickness in the average RNFL thinning with the CD ratio of 0.9 in the left eye, which was also correlating with our clinical fundus. And there was a severe thinning in 3 quadrants. So this is the case summary, sir. 60-year-old female patient with gradual painless loss of vision, diminution of vision patient complained more in the left eye since 3 years, who underwent NDI peripheral iridotomy in both eye and was started on glaucoma, anti-glaucoma medication, but was lost to follow-up. Vision in the right eye was 618 parts with improvement to 6.6, and left eye was also 618 parts improvement to 6.6. Anterior segment showed laser PI in right eye 12 o'clock portion which was not patent and 1 o'clock portion which was patent, and the laser PI in the left eye 2 o'clock portion which was nuclear sclerosis grade 1 on both eyes. IOP recorded was 18 and 26 by Goldman applanation tonometry, and gonioscopy showed grade 1 in 3 quadrants and 2 in one quadrant with peripheral anterior synecdoche at 2 clock hours. Fundus examination showed CDR ratio 0.6 and with NRR thinning temporally in the right eye, and CDR of 0.9 with NRR thinning in the left eye. So going to the final diagnosis, both eye primary angle closure glaucoma with nuclear sclerosis 1, left eye more than right eye, status post peripheral iridotomy. So our plan of management was, sir, as the patient is already on maximum medical therapy in the left eye and IOP is still not under control. So the patient is currently planned for left eye trabeculectomy, sir.
Thank you, Dr. Nivedita, for the wonderful presentation. I start with Sunita Dubey, ma'am.
Yeah, so very nice presentation. I just want to highlight 2 or 3 things. First, I will ask you why you have made, how come your diagnosis is primary angle closure glaucoma in both eyes? Because you have presented that right eye didn't have any damage. The visual field was normal, OCT was normal. So will you call it a glaucoma in the right eye also? Left eye, we can say that it is glaucoma. So how do you justify your diagnosis of...
Yes, ma'am.
Yeah.
Because the patient was already on anti-glaucoma medications. With that only, I had recorded.
Can you please stop sharing your slides? Yeah. Yeah. Okay. So patient was already on anti-glaucoma. That is why you say that the patient is glaucoma. She has connection. She has lost connection, it seems.
Hello, sir.
Yes,
we can hear you. I think you can just answer this question.
Sir, ma'am, because IOP was after putting anti-glaucoma medications, this IOP was recorded, ma'am. And one thing, ma'am, gonioscopy the grading was grade 2 on 2 quadrants and grade 1 on other 2 quadrants. With the CDR ratio was 0.6, ma'am. So glaucoma is there. That is the reason
on the basis of CD ratio, but what is the definition of glaucoma? I think you should read about the classification of angle closure spectrum. PAC, angle closure glaucoma, acute angle closure. Okay, so according to me, the severity of glaucoma is quite different in both the eyes. And the gonioscopic picture should also have been different because one eye has progressed so much, so it cannot be same. I think it would have been better if you had take gonio pictures. Do you have the facility to take the gonio pictures?
Ma'am, I had tried taking gonio pictures, but it was not coming clear. We used Sitlam and gonioscope.
And you had used gonio 3 mirror lens. Okay, so do you use gonio 3 mirror? So why 3 mirror? Why not 1 mirror or the Zeiss 4 mirror type of lens or Posner 4 mirror? So what is the difference? And what difference it would have made? Yeah.
Yes, ma'am. I should have used 4 mirror, ma'am. So that I could have done indentation and I could find out if it is an. I could make out if it was an oppositional type of closure or if it was because of cynical. For that, we need 4 mirror lens.
Yes.
So that it will displace the aqueous into the angle and it will open up.
Yeah. So with 3 mirror lens, actually you are not able to indent. Okay. So you can't comment whether you can open up the angle or not. So
Okay, ma'am.
as an
Yes, ma'am.
examiner, I would like to ask these kind of questions, like, because these are basic questions.
Yes,
Okay,
ma'am.
Pradeep Jain,
treatment
sir.
is,
Okay.
yeah, okay.
Dr. Pradeep Jain, sir.
Yeah,
Your
Nivedita,
Yes, sir.
yeah, I totally agree with Dr. Sunita. The diagnosis is definitely that in right eye, there's no glaucoma because there's no field defect in the right eye. And how, Nivedita, how many drugs that patient is using in right eye?
So right here only one drug he is using, sir. Bimetoprost at night.
No, right eye, what she is using?
Bimetoprost, sir.
Metoprost. And in the left eye?
Brimonidine, timolol, and bimetoprost.
So, in your presentation, you told ki she is using maximum medical therapy. So
Sir.
only we have 3
In the
drugs
left eye, sir.
for glaucoma.
No, sir, we have more drugs, but if we're using more than 3 class of drugs and still the IOP is high, and patient was also not tolerate not complying with the medications also.
No, but if you explain patient properly, and if the compliance is good, you can start one more, like brinzolamide is still left there for the left eye.
Yes,
So
sir.
you can use in combination brimonidine brinzolamide combination and timolol bimetoprost combination. You can try and then follow up the patient. And for right eye, you
Yes, sir.
feel ki that patient is using bimetoprost. So
Bimetoprost, sorry, only, sir,
maybe
the night.
bimetoprost for right eye. Okay, so can maybe like, and the fields are normal. So that
Yes,
treatment
sir.
was
Actually,
started by
this patient had lost
previous
follow-up. Previous
pardon?
people, sir. Patient had come to
Yeah,
us
that
to
was
that
that
this
drug,
treatment was started
that
by
medicine was
previous
started by.
people. Patient came to us 2 months ago.
Okay, okay.
So
Previous
now
consultant had
the
started, and then
pressure
patient
is
has lost
normal
follow-up.
for the
2
right
months ago
eye.
only patient came.
So you can stop that drug also,
Yeah,
that
pressure is
bimetoprost for
normal
the
for
right eye, and
right
follow the
eye.
patient.
Okay.
And for left
Okay, sir.
eye, you can add one more and again follow the patient. And then we can decide about the like surgery. If after using 4 drugs also
Okay, surgical, sir.
after using 4 drugs for the left eye, if the pressure is not under control, and one investigation, one corneal thickness is, you are not mentioned about the corneal thickness for this patient.
Sir,
So that is not done, I think.
corneal central corneal thickness was 520 microns, sir. 520
Okay,
microns.
that is there. So you
Thank
can add 4 drug and follow the patient, and for right eye you can stop that and follow the patient.
Okay, sir.
Yeah. Yeah, Dr. Deepak.
Sud, sir. Sir.
So, Dr. Nanda, that was a very good presentation. And actually, these are the kind of cases one commonly sees in one's day-to-day practice. So I'm not asking you a question because as I said, I don't come from a teaching institution anymore, but I just want to make some comments. This would be a good opportunity for the examiner to understand what is your concept of angle closure. Because angle closure is not a diagnosis by itself, but it represents a syndrome where it's very important to get into the mechanism by which the angle closure is happening. So when you say you did a gonioscopy, was there an indentation done? Did you look into the concept of a plateau iris or a plateau iris syndrome? Those are things that would need to be considered. Obviously, the trabecular meshwork function is disorganized or not optimal, and therefore you're having an asymmetrical rise in intraocular pressure. The other question that comes from the questions that have been asked is, what do you understand from maximal tolerable treatment? What is maximal treatment that is possible? These are changing concepts that are actually happening. And, you come to the decision for a glaucoma surgery and a trabeculectomy. Your actual diagnosis here is primary angle closure post laser PI with cataract, because the picture also had a fair amount of cataract there. Now my question is, the discussion can in an exam can come, how did you come to the decision for doing only a glaucoma surgery and not combining it with a cataract surgery? And then what kind of glaucoma surgery do you plan to do and why? These are points of discussion that I think would be what an examiner can ask you.
Very true, sir.
Thank you, sir.
Dr. Sivanand, sir, your view on this case, or what are the things in your mind before you thought that this should be presented here to
Yes, sir.
teach other people, other residents?
Thank you, sir. Thing is, for every postgraduate, this a lesson that they should know the gonioscopy very well before commenting diagnosis, and they should know how to read the visual fields. And as sir mentioned, even corneal thickness plays important role, and maximum therapy, glaucoma therapy, and in this case, especially compliance of a patient in a glaucoma is very important. So proper follow-up and compliance of the patient in glaucoma cases we have to do, because this case almost lost the follow-up for 3 years. Then when she had a complaints back. So in last 3 years, how properly she has put the drops and all that. So these all things we have to keep in mind and go ahead with the further management of the case. Thank you.
Thank you, sir. Thank you. So at the end of this landmark episode of 125th of the IVS-ARC PG teaching program, with the folded hand, I would like to thank all our experts of today, Sood sir, Jain sir, Madam, Sunita ma'am, and both the mentors, Dr. Amit Bhai and Dr. Sivanand sir, and both the presenters, because it's just a team unless you present, and I'm proud to say that both of you presented very well. I'm telling you one thing, your experts are not an easy expert. I always at the starting I said they are the teacher of the teachers. Sood sir, Jain sir, they have created a lot of generations of glaucoma surgeons. Even those who are the experts are not feeling so well or doesn't have courage to face them so boldly. So everyone, thank you for your presence and your consent and helping Team IVS-ARC in this way. And at the end of this 125th episode, I would like to thank all the viewers also. And in the starting, we missed the two names of the IVS-ARC backup team who supported us a lot to reach this stage. One is Dr. Pallavi and another is Tushar, who is coordinating each and every one from all of us here to there. And our IT team, Sunil, Mr. Sunil, he every time help us, means this and that, whatever we can say. And thank you Tushar, Silpi and Sunil for arranging and providing us all these help of the IT team and other one. And thank you everyone. Thank you for joining this one. Thank you, sir. Bye.
Thank
sir.
you very much, everyone. Thank you.
Thank you, everyone. Thank you, Team ARC. Thank you, Sood sir.